Hello, everyone. So let's see. This is a recorded lecture because this is for the for Module 3 for May 30th, and I'm going to be traveling that day, so I'm taping this lecture. What I would like for you guys to do in order to get attendance points, if after you watch the video, you could just email me and let me know that you watched it, and then I'll give you attendance credit. And of course, if you have any questions about any of the content, please feel free to include that in the email too. So I'm going to go ahead and get started by going through some of the topics by using my PowerPoints, as I call them, Death by PowerPoint. Just kidding. Hopefully it's helpful when I use these kind of as a guide, and it also helps me kind of know where I'm at. Let's see. And okay, you guys should all be able to see this here. And this is chapter 6 again. It's a motivation, adherence, collaborative treatment planning. And I've already opened up the module on this in terms of the homework and everything. So if you haven't done the homework yet, then hopefully the information that I share with you today is going to be helpful doing the homework. So let's go ahead and get started with some topics here. So the motivation part of chapter 6 is they define it as a psychological construct that arouses an individual to take the actions needed to achieve a goal. So we all know what motivation is. In fact, students are kind of frequently confronted with motivation or lack thereof when you guys are trying to do homework or study for an exam and things like that. So maybe you'll even take some information from this chapter to help yourself in goals and things that you're trying to be motivated in, whether it's school or other issues. Adherence. So the chapter talks a little bit about adherence. So how do you adhere to being motivated, or how do your patients adhere to be motivated? Adherence, another word for it that we commonly use in the medical field, is compliance. We've kind of steered away from that word. It sounds kind of paternalistic, and we've gone to more of an adherence thing. So adherence is the degree to which clients follow treatment. And it can be measured by things like clinic attendance, the degree of adherence. So like say if somebody's trying to quit smoking and they come in first and they tell you they're smoking a pack a day, and then the next time you see them, they're half a pack a day. So that's obviously progress in reaching a goal. There's self-reports. So that might be, the same thing. Going from a pack a day to half a pack a day. It might be people who their blood sugar, they have diabetes and they're working on decreasing their blood sugars, and so they maybe keep a journal of that. The clinician's assessment about it. So based upon what the client's telling you and your objective findings. A multivariate approach just means there's different ways, and the chapter talks a little bit about different measurement tools for measuring adherence. There's a theory about motivation by this fella called Julian Rotter that involves locus of control. And we talked about this a little bit, I think, in the chapters 2 and 3, about how people kind of view their ability to take charge of their lives, whether it's their own internal kind of locus of control versus external. So internal locus of control means you yourself, inside of yourself, feel that you have control to change things. External means that you yourself don't have the power necessarily, but forces outside of you do, whether it's your family, whether it's your religion, events that are beyond your control. And it turns out, as you might imagine, that people who have more of an internal locus of control seem to have an easier time with motivation and adhering to goals because they feel they have the power to make the changes and do what's needed. If you have an external locus of control, then you depend on other people. And while sometimes that can be very effective, sometimes it's not very effective. Self-efficacy kind of goes along quite a bit with the locus of control issue too. So again, that's whether somebody feels that they themselves are able to make changes. Are they efficacious in terms of their own ability to make changes? So it says Bender, this is a person who did research and introduced the concept, but it's belief in one's ability to achieve a task, to control one's actions and behavior. So it's very similar to locus of control. Another issue that comes into play is self-esteem and how people feel about themselves. People with strong self-esteem tend to have higher motivation to be actively involved in their care, and they believe they have control of their life. So those three, locus of control, self-efficacy, self-esteem, play big roles in motivation. Other things that play a role in motivation and adherence are things that they've done studies on. Race, ethnicity can oftentimes play a role, and particularly that has to do with somebody's culture, maybe the community in which they live, as it relates to these other things too. Literacy, certainly there are people who can't read, whether they English is a second language, or maybe they grew up in a poor and they can't read very well. That can clearly limit their ability sometimes to be motivated and to adhere to goals, especially if you as a healthcare provider are giving them, a book to read or some resources that they're unable to really take in to get anything from. So one time I had a patient at a clinic, and I was reviewing with him his medications, and I was looking at, he brought in the bottle, and I was trying to assess how often he took it. And finally I realized he could not read. But oftentimes people who have low literacy levels are embarrassed by it, and they might not tell you. And so if you just assume that everybody can read, then you might have a major problem there trying to get people the right resources that they need to make changes. So pay attention to that in your future, the literacy issue, because we tend to think everybody can read, but that's not always the case. Their educational level, so communication, I think that was our last chapter, is really important to be able to talk to people in the educational level that they can understand. Income, because socioeconomic resources plays a role. Where people live, again, resources and social support. Obviously, if people have a family or a community that is helpful to them in trying to reach their goals. So like, say if you have somebody who is an alcoholic and they're trying to reduce alcohol or quit alcohol, if they have a strong social support system that helps them, as opposed to all of the friends being alcoholics or liking to drink, then that's going to play a role in inhibiting that person from reaching their goals. So social support. So people who have social support, as you might guess, have greater optimism, less depression, less anxiety, improved quality of life, higher self-esteem. So because of all those things, they have a greater adherence to treatment. And that's kind of intuitive, and it's borne out by studies as well. So what kind of things affects people's motivation and adherence? Again, those three things that we just talked about: locus of control, self-efficacy, self-esteem, and of course the variabilities that go along with their illness and disability. So depending on how severe their illness and disability is, obviously is going to affect their ability to be motivated and adhere to goals. And adhere to treatment modalities. And again, the social support, not only by family and friends, but also that provided by health professionals. And that's not just doctors and nurses, it's physical therapists, it's CMAs, CNAs, all kinds of people that are involved in somebody's healthcare, counselors, things like that. Other things that affect somebody's motivation and adherence, well, certainly their psychological state. So if somebody's depressed, maybe they've had a stroke and they're either depressed because of their abilities to do things for themselves might be affected. Maybe they can't speak as well as they used to speak, and things like that that could kind of trigger a depression. And it can be very hard for people to get motivated and adhere to a treatment plan if they're depressed. Same thing with anxiety, maybe feelings of inferiority. One of the things that we'll talk a little bit too in the loss and grief chapter, when people's life circumstances change significantly and they aren't able to do the things maybe that they're not as independent that they used to be, maybe they feel inferior, and that can certainly be a barrier in motivation. Maybe they feel shame, guilt. Maybe it's a breadwinner for a family, and now that person can't work anymore because of an illness or a disability, and they might feel guilty about that. And then people who are in denial or have fear are oftentimes, those are barriers to doing the things that they need to do to reach their goals. Other things, certainly somebody's culture, and that goes back kind of the locus of control and self-efficacy. But if your culture, say, reveres people who are able to do things for themselves, people who, maybe your culture shuns people who have a disability, things like that, that can play a big role. And then your own health and healthcare history. So if somebody has a health, if they say have a sudden illness and prior to that they were very healthy, then that can play a role in motivation and adherence, because this person's what we call pre-morbid lifestyle. If they were very independent and they were used to taking charge, then that can sometimes hold them in good stead afterwards, after they have an illness or a disability. Like, let me give an example. Your book gives an example of Christopher Reeve, the actor who played Superman, and he was in that terrible accident where he became paralyzed. It was a horse riding accident, and he became paralyzed from the neck down. But prior to the accident, he was a very successful actor. And afterwards, he became a major spokesperson for spinal cord injuries. So that's somebody who had a health history that was very good. And he was able to kind of move that forward and had good self-esteem and locus of control and things like that. So he was able to kind of move forward beyond his illness to be able to help other people. And then, of course, there's practical concerns. A practical concern can be something as simple as somebody getting to an appointment. Now, oftentimes in doctors' offices or physical therapist's office, things like that, if somebody doesn't make an appointment, we think, they're not compliant, they're not adhering to the plan. But it might just be that person, depends on somebody else for a ride, or they depend on the bus, and the bus couldn't get them there on time. So there's lots of practical concerns. Money is a practical concern. So somebody might be embarrassed to tell you that they can't afford their medication. So they just say, oh no, I didn't get that filled. And then you as a provider might think, oh, well, that person doesn't want it. They don't even want to help themselves. They're not even getting the medication. When maybe there's a lot more to it. So what's really important in motivation and adherence is that the healthcare professional and the patient are on the same page, right? So the congruency of the goals are really important. That gets back to communication too. So you as a clinician need to make sure you're on the same page with the client in terms of their goals. So your goal might be for them to stop alcohol completely. Well, that might not be their goal. Okay, so before you just push your goals on somebody else, make sure you guys are working from the same page, and make sure that whatever goals that you and the patient are working on are consistent with the client's attitudes, their beliefs, their values, their style of self-regulation kind of thing. So in other words, if you're working with somebody, say, who's got diabetes, and you're trying to get them on a good dietary lifestyle where they're eating the right foods, because that is so important in people with diabetes. Well, if that person relies on somebody else to make their meals, then you have to make sure that you're bringing that other person into the conversation too. So say if it's a husband that you're dealing with, and the wife makes all the meals, but the wife is used to making very high carb meals, lots of sugar, things like that, then you have to make sure you're on the same page with that person too. And that goes into education and all kinds of things, which we'll talk about too. So level of knowledge and skill, you have to take that into consideration, because if a person doesn't know a lot about their illness or disability, then it's upon you to educate them in a way that they can learn about it. And the healthcare professional needs to empathize with the client's needs, not sympathize, right? Empathize, and incorporate a treatment plan that's individualized to the patient. Obviously, one size does not fit all. What kind of barriers are there? Well, it's clearly knowledge. If a patient doesn't know what they should be doing or what the problems are associated with their illness, then it's really important to educate them. So knowledge is important. Assessing somebody's readiness to change. This is common in, and we'll talk about this a little bit more, in people who need to make changes, like say for smoking, alcohol problems, drug problems, where they are in the readiness to change scale. Again, the shared goals, the pragmatic problems, like can they get their medication? Can they get to, like say if they have alcoholism, can they get to their AA meetings? Working within their illness parameters. So you have to be realistic as a healthcare provider. Addressing depression and hopelessness, because when people have chronic illnesses, disabilities, oftentimes this plays a role, and you're not going to get very far. The patient isn't going to get very, very far unless these issues are addressed. And again, the self-efficacy and locus of control. So if people don't feel like they can do what they need to do to help themselves, or that locus of control is external, trying to help them have more of an internal locus of control, if that's possible, to help them in their goals. There's a little section in the textbook about goals, and it's really important as a healthcare provider to help people establish goals. Now, again, they need to be goals that really come within the patient, and we're going to talk about that a little bit more with there's some models of promoting motivation and adherence. But short-term and long-term goals are really important, and if they're relevant to the patient, and the patient feels like they're attainable goals, then that can be very, very helpful. So like say if somebody is obese, instead of saying, okay, you're going to lose 10 pounds this week instead, or this month, instead maybe set very kind of very achievable short-term goals with the idea of not overwhelming people with a long-term goal. Okay, so I call that baby steps. Again, clients need to adhere to programs that aren't too difficult, because you're just setting everybody up for failure if you have a program that's just too difficult or complex. Not too costly, okay? Again, so if you prescribe I know somebody who recently got prescribed a medication that their insurance wouldn't cover. It was $1,000 a month. So that was ridiculous. The person could not afford that. Not too time consuming. So like say if somebody's had, has chronic low back pain, and you say, okay, you need to go to the gym, or you need to go to physical therapy 3 times a week, and somebody says, no, I just cannot do that, and you just ignore that and you say, well, you got to do it, then that's not going to be helpful. And are consistent with their health belief system. And I'm going to hold off on that for a minute, because we are going to talk about this, one of the approaches to motivation, and that's working with people within their health belief system. And that's here we come to that. So your book talks about 4 different strategies for enhancing motivation and adherence. And I'm not going to talk a lot about them. Your book goes into each one pretty deeply, but do pay attention when you're reading these, because your homework, one of your homework things is to review a case about a man named Ted who has chronic low back pain, and things that you're doing as a healthcare provider to help him deal with the low back pain. And which I'm asking you in the case study to pick one of these models and to use it to try and help Ted make changes in his lifestyle. Okay. So the health belief model has to do with approaching a patient with what you believe are their own health beliefs. Okay. So that requires that you have to get to know somebody and kind of understand how they view their illness or their disability, because you might view it in one way, they might view it in another way. And so how they view it in terms of how it affects their lives, how they, what beliefs they have in terms of improving themselves, what their goals, what motivates them. So that's really, it's almost kind of a psychological model in trying to understand where somebody comes from. Because if you as a healthcare provider approach it in a different way, then you're just going to create a barrier, and nobody's going to be happy with that. This one is, you probably have heard of this one, the Trans-Theoretical Model for Health Behavior Change, also known as the Stages of Change. This is very common in, like say, drug and alcohol and quitting smoking. So this is the one where you assess where somebody is. Are they at the pre-contemplation stage? Like say if somebody comes in, they want to help, well, say if you see somebody for a problem and they're a smoker, and you ask them, oh, I see you're a smoker, what are your thoughts about quitting smoking? And if they're like, nah, not interested, then they're not even in the pre-contemplation stage. So there's so whether or not to give them a bunch of information at that time and to lecture them is probably not going to be very helpful. But where we as healthcare providers can make differences depends where people are in the stages of change. And there's 6 of them that the book presents. Pre-contemplation, so that's where somebody says, well, I've kind of been thinking about it. My wife's been nagging me. I'm thinking about it. So that's pre-contemplation. Contemplation is like, yeah, I am thinking about it now. I'm really, interested maybe in getting some information, things like that. Then there's preparation. So that's when somebody's really preparing, like, okay, I think I'm going to quit, 3 months from now. Then there's the action stage where somebody's actually, maybe they're taking a medication to help them quit smoking, or they're actually, in the mode where they're cutting back, or maybe they've quit cold turkey. Maintenance, of course, is just maintaining the change, and then termination when they're done. So that's a very common one that you've heard about probably in one way or another. The 5 A's is kind of similar. The book goes through addressing somebody's problem or issue, assessing the client as to where they are with changing, advising them on what they need to do, assisting them, and then arranging for specific things, whether it's medication, counseling, things like that. The last one I think is really interesting, and I think this come more into vogue in recent years, motivational interviewing. So this is an interview style that in some ways is kind of like the health belief model, but it's asking people about their problems, their issue, their illness, their disability, and ascertaining where they are in terms of being motivated to change. And if somebody says, yeah, no, I know I need to lose weight, and then the idea, you ask them questions about, okay, well, what is it that's in your way? What are the barriers to this? What do you see as something I can offer you to help? So it's very much a listening kind of evaluation, and it's also has to do with finding a discrepancy. So people might say they want to change, and then you're trying to find that, or maybe people saying, yes, I know it's not good for me to smoke, or it's not good for me to eat high sugar things if I'm a diabetic. So they know it's not good for them, but then yet they proceed to keep doing those behaviors. So but it's trying to bring it all back onto the client or the patient. It has nothing to do with a healthcare provider shoving information to a patient and shaking their finger at them. And instead, it's really trying to get at the person and what motivates them, and how can you as a provider be helpful to them. So when you're reading the textbook, you actually it might be good for you to read the case first, the homework case, and then as you're going through these, see which one you want to use for your homework model there. Strategies to enhance motivation and adherence are to give people education, to empower them. And you have to be careful on the education thing, because you don't want to overwhelm people, and you want to give them education, meet them where they're at. So again, if it's a young person, they might want their education all online, digitally. So you might say, oh, here's a good website, here's an app. There's so many apps now. If it's an older person who's not very computer savvy, then again, more traditional written materials. Again, you want to empower the patient and give them the tools, because they'll be more likely to be motivated than if you just say, here's what you need to do and do it like I say. So again, this whole client-centered focus, this goal setting, encourage the patient to come up with their own goals, because they'll be more likely to adhere to them. Give them feedback and follow-up. So if you're going to see somebody in clinic, especially for, like, say if you're a physical therapist or a physical therapist assistant or an occupational therapist, you want to give them feedback on how things are going. You want to follow them up closely, because studies have shown that people who are trying to make changes in their lives do better if they have frequent and close follow-up. And know the peer support groups that are in your community, because those can be very helpful, whether it's somebody who has had a stroke and needs and could benefit from a support group, or somebody who maybe just would need steering to a local Alcoholics Anonymous group or Narcotics Anonymous, things like that. Functional programs, that is basically things like physical therapy and occupational therapy, things that actually help people function or help them with physical, and it can be mental health too, counseling, things like that. The primary and secondary control enhancing strategies, the book gives an example there, and what they're trying to do, what they're trying to stress here is that there are primary strategies, and that's where I think the book gives an example, something about a woman maybe who's had a stroke, and one of her favorite things is to go to, she must live in a big city, is to go to the neighborhood newsstand, but she can't, her physical capacity is declining. So one of the strategies is to have her have a wheelchair, and then she gets to the newsstand that way. But over time, as her condition declines, she's unable to do that. So the secondary strategy would be to figure out a way where she can still get her news, and basically, instead of controlling the environment by using a wheelchair, instead adjusting her expectations and having the paper delivered to her. Okay, so it's kind of a external control versus an internal control, and this requires a lot of creativity and flexibility. And collaboration, of course, not only collaboration with the client and the healthcare provider, but collaboration with the family, with caregivers is really, really, really important. Collaboration with other providers, so maybe collaborating, I think it's really important with physical therapists, occupational therapists, psychologists, things like that is really important. What are the barriers to collaboration? Well, clinicians see it as sometimes a barrier is that the patient isn't adhering to the plan. Maybe the physical impairments or mental impairments and disabilities get in the way. Maybe the patient isn't interested in collaborating, or maybe the doctor or the healthcare provider isn't. Maybe the client thinks the clinician doesn't have enough time to help them, and maybe the client isn't certain that it's going to be successful, so they get frustrated and aren't very motivated. Other barriers are either the client or the healthcare provider really don't know how to collaborate. They're just not sure how to get on the same page. Maybe there's an unwillingness to relinquish or share power. That happens, I think, on the healthcare provider, and because they think, oh, I know what's best, and that's that paternalistic perspective. And in general, that's better than it used to be. I think, as patients have become more empowered and more in tune and educated, and for all of the problems, I think that sometimes the internet causes, it can be helpful in people educating themselves. But sometimes they get on sites that aren't very helpful. And then also I think oftentimes clinician fail to consider pre-morbid lifestyle and history. So sometimes a healthcare professional first meets somebody at the time where they haven't met them before, when they were ill before. Haven't met them prior to becoming ill or disabled or what have you. And so they don't know what they were like before. And it's really important to kind of ask somebody, well, how would you handle this before you got hurt or what have you? Because that some people, that can be very helpful, because if a person was very independent before and now they're not, then at least it gives you a better feel as a healthcare professional about, is this somebody who would be maybe willing to take on some challenges to become more independent? Let's see where we are here. Other strategies, again, this is that client-centered care, asking clients to identify questions and problems in their own words, making sure you have an open dialogue, and educating clients about how to be active participants. So motivation and adherence to goals works much better if a client feels they're an active participant instead of just kind of at the mercy of what others expect of them. Okay, so that's the end of those slides. And hi, I'm still here. Shoot, I'm not sure what time I started this. I don't want to go over an hour, and because I'm doing this lecture just pre-recorded, I don't have a little time clock on here. So I'm just going to power through to the next one, the loss and grief. I don't think that one's quite as long, so hopefully I'm not going over an hour. And next time I'm going to remember to look at my clock to see when I start the broadcast. So let's move on to loss and grief. Let me kind of find my place here. Screen share. Let's see. Okay, I've got my slides up here, but I think I need to go. Okay, so let me shoot. Sorry, somehow this went to the very end. Let's move this up a little bit. So this chapter is on loss and grief, which all of you at this point in time in your lives have, I'm sure, suffered some sort of loss and grief, whether it was a loss of a grandparent or a family member, or maybe a family member's a friend of the family, things like that. So this is, I think, a chapter that, from a personal standpoint, probably most of you can relate to, others more so than. I mean, not everybody at the same level, of course. So we're going to talk about loss and grief and the adjustment that people make after having losses. And one of the things that usually when we think of loss, we think of somebody who died, right? Whether it's a family member or a friend, but we're going to talk about other kinds of loss too, because that's really key in this chapter. So that's the loss associated maybe with maybe somebody has a chronic illness or a disability, and maybe they have a loss of abilities to do what they used to do. And the losses associated with chronic conditions, also losses associated with the person who's giving care to somebody who's ill, because they themselves also have loss too. And we'll touch on losses for the clinician as well. So types of grief, we'll talk about that: acute grief, chronic grief, grieving behaviors, the stages that people go through, the outcomes, and a concept called chronic sorrow, and how people adjust. What kind of coping behaviors, what kind of skills can we help people with, the adaptation strategies, and developing a therapeutic response. So types of loss: sudden loss, maybe somebody was in an industrial accident and they lost an arm. Gradual loss is, of course, more so with chronic illnesses. So maybe somebody has, like a neurodegenerative disease like multiple sclerosis or ALS, Lou Gehrig's disease, where over time they're losing their ability to maybe say walk or to see. Things like that. So those would be more like gradual losses. Anticipated loss, so that's something that you know that is going to happen. And that could be something like somebody has a terminal illness. And so the loss is that the anticipated loss is, say, if the doctor says, oh, we think they have 3 to 6 months to live, then that's an anticipated loss. Uncertain loss or ambiguous losses, we'll talk about that a little bit. That oftentimes has to do with people maybe who their memory is going and it's kind of ambiguous or not very clear to the patient themselves. A total loss would be more like a death. A partial loss would be maybe more like a disability that somebody suffers from. Permanent loss is obviously that, as opposed to temporary. Age-related loss, so that's as people age, maybe they'll lose ability to, maybe their vision is going, maybe their hearing is going, things like that. And then the primary internal and external losses. So a primary loss is when, like, say you can't, maybe you have had a stroke and you can't use the right side of your body. The secondary loss might be that you can't work anymore, okay? And loss produces by other losses. So if you can't work anymore, then maybe you have other losses because you can't have the income that you used to have, or maybe you're dependent on somebody else, or maybe you've lost an important social kind of interaction or social life. Maybe the work that you did provided you with social opportunities that you don't have anymore. Then, of course, loss of social roles and autonomy. Those are huge. So if somebody maybe becomes paralyzed or they have a debilitated condition and other people have to take care of them, then they don't have that autonomy or independence, and that can be a huge loss. Ambiguous loss, that's the kind of uncertain or incomplete loss. Maybe somebody's physically present, but emotionally or cognitively unavailable. For example, somebody might be in a coma, they might have had a traumatic brain injury, dementia, mental illness, and even chronic pain is kind of an ambiguous loss. Like, we can't always see that somebody's in chronic pain, but somebody might have something like fibromyalgia or something like that, which we're going to do a case about that in a later chapter. And then there's other kind of incomplete losses, which maybe somebody has a family member that's a soldier missing in action, maybe a missing child, and again, these degenerative or chronic illnesses, or an illness that you're just not sure what the course is going to be. You know, maybe somebody has some sort of arthritis and they're not really sure, how is this going to affect me in the future? Am I still going to be able to use my hands? Things like that. And again, the person's present, but not as she or he was before. Like say if somebody's maybe had a stroke, or well, particularly if somebody has dementia, you grieve what you lost, and then you're still trying to figure out how to have a meaningful relationship with the person you now have. Ambiguous loss can be a powerful block to coping and grieving because it's hard to put your finger on, and the grief sometimes can't be resolved. So this can be very difficult. Loss associated with chronic conditions. So these are situations where maybe people have a disability, maybe from a traumatic accident, maybe they have a debilitating medical illness like MS, multiple sclerosis, something like that. Maybe they have a child that was born with severe cerebral palsy, things like that. So in a later chapter, we're going to talk about disability and coping and things like that. So there's long-term issues to manage. Sometimes there are things that sustain, so they're kind of more permanent, or some things that kind of come and go. The psychological distress that can come with chronic conditions. And then sometimes there's positive things that can come out of it too. Like people realize they have a strength that they never knew they had, and maybe they feel like they can make a difference. Like for instance, Christopher Reeve, which I just mentioned, and how to integrate loss into somebody's life. The personal caregiver also has loss. So like say if it's a parent of a child who has a disability, that can be very demanding, and it can have big effects. If the personal caregiver is, say now, a husband of a wife, and the wife used to always be the one doing the cooking, then that's, that can be viewed as a loss. And just differences in social and family roles. If somebody has a chronic illness or a disability, it can really affect the dynamics in the family, and that can represent a loss. A loss for the clinician. So depending on the type of clinician, obviously cancer, people who work in cancer care have lots of losses, or people who work in hospice care have lots of losses. Sometimes people might have a lot of mini losses, like they might work for the military hospital where they see lots of people who have maybe traumatic brain injuries. Not that that's a mini loss, but where maybe there's not death, but people have kind of maybe either temporary or other kinds of situations where they lose their ability to maybe to work or to be fully involved in a family. It is an occupational hazard. Of course, anybody in the healthcare field knows they're going to work with people that are going to have some sort of loss due to illness or trauma, disability. And it can be very difficult for clinicians, because clinicians sometimes, if they know somebody's not going to live, then sometimes they might even just try and kind of wall themselves off from that, and they might not, they might actually appear cold and formal with a client because they're trying not to get too close to somebody and trying to kind of protect themselves, really. So, and then they can have unresolved loss and grief too. Sometimes they feel guilty because they couldn't help somebody. So these are very real for clinicians too. And these are things to keep in mind as you, if you end up, which I know many of you want to be in the healthcare field, that you yourself can have losses pretty much no matter what area of healthcare that you're in. I work at a student health clinic, and you would think that it would be rare for me to have losses, but we have had students here who, whether they came to us already with an illness or they ended up having an illness, and we've lost a few students here. We've had students that at the university who have died of suicide, a few have died of cancer, and it's heartbreaking. So I think what I want to say here is if you find yourself in the future where you feel like you're having problems dealing with losses, make sure that you get professional care. See a counselor for that. I think that would be a very smart thing to do. So grief and mourning is natural across all cultures. All cultures have some way of dealing with grief and mourning. And it can, as you all can imagine, it really can vary. It is influenced by religious and social mores or values. Um, there can be psychological and physical signs. So, like in some um, cultures, if a husband dies, a wife might dress in black for a year, or might go into some kind of mourning for a specific time period. And generally, in the Western way of dealing with grief, sometimes I think we hurry people along with it too much. We say, pull yourself up by your bootstraps and move on or accept the loss, maybe sometimes too quickly. But the goals of grieving are over time, people accept the loss, they heal and recover. Okay. And recover means kind of moving on in life. Obviously, we can say the wrong things to people sometimes. We never want to say, oh, you'll get over it. Whether it's somebody who has lost a child or a husband, or they themselves maybe they've lost a limb, maybe they had to have a amputation due to diabetes and things like that. So there's different types of grief. I don't think I'm going to go into all of these, but anticipatory grief, or when you are grieving, maybe you have a spouse that has cancer, and so you're already grieving that maybe you've been told that cancer is terminal, and so you're anticipating the grief. And so sometimes this actually can help people after a family member or friend dies, if they've already kind of gone through the anticipatory grief. Acute grief is what happens immediately. Chronic is over time. Delayed or suppressed is maybe it doesn't happen now, but people will feel it later. And we'll talk a little later about chronic sorrow. Influences on grieving behaviors. So religious beliefs, age, your culture, just your personality, and of course the relationship between who is grieving and what is lost. If you've lost a child, that's a whole different way of grieving than if you've had to have your big toe amputated, obviously. Behaviors associated with acute grief. So certainly all of these are common: crying, wailing. This seems to be wailing is culture dependent, not as much in the Western way of grieving. Withdrawing, social isolation. People oftentimes lose their appetite. Difficulty sleeping is very common. Losing interest in one's enjoyable things, which is common in acute grief, but over time, people that shouldn't continue unless it goes into kind of a chronic grief, which is more of a pathological condition. And this is very common too: feeling numb, hopeless, helpless, confusion, memory loss, difficulty concentrating, making decisions, and decreased problem-solving skills. These are very, very common with acute grief. Now I want to go into a little bit the Kubler-Ross stages of grieving, and then there's the integrative theory of bereavement and tasks of mourning. So these are just three of many models of grieving. And the one I'll pay a little bit more attention to is Kubler-Ross, because as part of your homework, you're going to watch the Kubler-Ross video on death and dying, and then write a little kind of short paper about what you learned about that in the discussion board. So the first stage that Dr. Kubler-Ross discussed was denial. So denial is kind of like shock in this integrative bereavement theory, and it's where you're just basically saying this didn't happen. So maybe a family member or you were given a diagnosis of a terminal or a very progressive illness. Second stage would be anger in the Kubler-Ross Third would be bargaining. So trying to maybe, if you're a religious person, bargaining with God that if you could just live for another year to see your daughter graduate from high school or something like that. Depression is depression. And then the last one would be acceptance. Okay. What kind of influences are there on grief outcomes? Well, it depends on what the physical outcome is, and how severe it is. Does the loss cause dependency? So if you relied on your spouse for, say, financial dependency, and now your spouse has died, who are you going to be dependent on? Or maybe you had a stroke, and so who is going to take care of you? If you don't have good social support, are you going to be isolated, lonely, things like that? Are others going to react negative to you? So maybe somebody has a severe burn on their face, and they have bad scarring. Kind of your self-esteem and reactions that other people might have of you might play a role. What were you like before you got sick or ill, or had a traumatic event? Your life history, cultural roles, your role in your family and in your community, has that changed with this loss? How can you integrate it into your life and hopefully still be able to be a productive person, or somebody that at least feels like you have a reason to go on? Do you have sufficient resources? If you don't, then that obviously can play a big role in grief. If you have a physical illness, then some people have this excessive, protracted, or chronic grief, and that's a whole different animal. And how do you use effective coping strategies? Chronic sorrow is a little bit different. Chronic sorrow is not really chronic grief. Chronic grief is kind of pathological. So everybody that has a significant loss goes through an acute grief. And that just varies by how long it takes. It might take a month, it might take a few months, it might even take, upwards of a year. But when people have chronic grief, oftentimes they're unable to move on in life. And I'm not talking about chronic sorrow, I'm talking about chronic grief. And I know there's not a slide for this, but it's in your book. So chronic grief is when people are unable to kind of move forward, and they're kind of get stuck, okay? And depression oftentimes happens with that. So depression doesn't usually happen with acute grief, or if it does, it's short-lived. But people with chronic grief need usually different care kind of modality. They need counseling, they might need, they might benefit from antidepressant medication, they need maybe support groups and things like that. Okay. Now, chronic sorrow it's when people grieve or have sadness over the loss of say, milestones. Like, say, if you lost your parent at an early age, you might grieve that they're not going to be around when you get married or when you have your first child, kind of a thing. So maybe somebody's going along fine in life, but they're kind of hit by a wave of sorrow because they lost their child, and they're, watching a movie about a family, and it brings it all back to them, or something like that. So there's lots of milestones, and that can be from any setting. It can be, somebody who has a disability themselves, and maybe they can't have children. And so they have this kind of chronic sorrow that comes up from time to time, that they are not going to reach, or their family members aren't going to reach these milestones. The book gives an example about somebody who has a child with a disability, and they have sorrow that this child is not going to get married and go to school and things like that. Loss of future plans. So somebody who maybe is married and they lose their spouse, or maybe somebody who is now confined to a wheelchair, and they had big plans to travel in the future, and now they feel like they aren't going to be able to, or not in the same way. Lifestyle adaptations hopefully help people with chronic sorrow. But the big thing about Chronic sorrow is this episodic feelings where it's different than chronic grief, which really people can get stuck in and it's pathological and they can't move forward. Chronic sorrow is more episodic. It happens from time to time, and sometimes people can put their finger on why they have an episode of sorrow, and other times they aren't even sure why it hits. And antecedent events basically can be triggers too. So like say you think of something that you used to be able to do, or that you used to do with your spouse who has passed away, and that might be a trigger. So anyway, that's kind of what chronic sorrow is. So that's the end of that chapter there. So we're done for this module. So again, drop me an email and just let me know that you watched the video here, and then I can give you credit for attendance too. And then just do your homework for this time. It's all in Blackboard, and it's due June 6th, a week from May 30th. So if you have any questions, just drop me an email. I'm going to be traveling a little bit in the next few days, but I should have some access to email and stuff. So hopefully you guys have a great week, and I will see you next on June 6th when we actually do our regular classroom, and then we'll do it through Collaborate Live, okay? I'm only doing this right now as a link through YouTube because I can't do Collaborate Live unless somebody else is tuned in, because otherwise it's not collaborating, I guess. So, okay, thanks guys for your attention, and see you next time.